I thank him so much for his great effort, also to OrthoTV and to Eva Pharma Company. Today we have two great speakers and two eminent professors, Professor Murali Poduval from India and Professor Mahmoud Hafez from Egypt. We'll start with Professor Murali, and Professor Murali will speak about a very important topic, the basics of artificial intelligence and machine learning, and an overview of potential applications in knee arthroplasty. Dr. Srinivas will be the moderator of this session. Please, sir.
Thank you very much, sir. Good evening, everybody. As always, I would like to thank Professor El-ashhab, Egyptian Orthopedic Association, Indian Orthopedic Association, and OrthoTV for this wonderful experience. Our speaker today is Dr. Murali Poduval. He's a good friend of mine. He is a senior consultant and medical device engineer at Tata Consultancy Services in Mumbai. Sorry, there's a spelling mistake there, in Mumbai. He's also a colleague to me. He's an associate editor for Indian Journal of Orthopedics, and he has over 25 years of experience in the field of orthopedics. He did his MBBS from Grant Medical College in Mumbai and MS Orthopedics and DNB from GS Medical College and KEM Mumbai. He has a postgraduate diploma in management with specialization in healthcare administration from Wellinkar Institute in Mumbai, and is certified in design thinking, innovation, and leadership coaching. He is formerly additional professor at Department of Orthopedics in Jipmer, Puducherry, and associate professor, Asian Institute of Medical Sciences in Malaysia, and again at Pondicherry Institute of Medical Sciences, associate professor at Manipal Institute of Medical Sciences, Nepal, and assistant at Seth GS Medical College in KEM, Mumbai. He's working as a senior consultant in medical device engineering at Tata Consultancy Services since 2018, and associate editor for Indian Journal of Orthopedics for the last 5 years. He's the chief editor for Medscape Orthopedics, and his special interests include total joint arthroplasty of the hips and knees in younger children, younger patients, adult reconstruction, including limb lengthening and deformity correction, and orthopedic technology, artificial intelligence, and machine learning in medical imaging and connected digital health. Thank you very much, Dr. Murali, for accepting the invite. He's also a very good photographer. If you happen to see his Facebook page, he takes very good photographs. Dr. Murali, please. Thank you.
Thank you, Srinivas. Thank you for that kind introduction, and I will share my screen now. Let's get straight down to business. And thank you for this honor of, being able to speak in this wonderful collaboration between our two countries. I'm just trying to. Is my screen visible in full screen?
Yes, sir.
Can somebody confirm? Yeah. Is my screen visible?
Yes.
Okay, thank you. So thank you very much, my dear colleagues from Egypt and from India, for giving me this opportunity. It's great pleasure for me, and I cannot express it in words. But I will be speaking to you on a topical subject, which is the basics of artificial intelligence and machine learning, and an overview of potential applications in knee arthroplasty. So Srinivas has already spoken a lot about me, so I won't speak about myself. Let's start with a few quotes. Satya Nadella, the CEO of Microsoft Corporation, said that ultimately humans and computers will work together, not against one another. I'm starting with a quote from Satya Nadella. I will end with some quotes from Satya Nadella. Alan Turing, who's considered the father of artificial intelligence, he once said that we can see only a short distance ahead, but there's plenty that needs to be done. And I feel that this quote, which I put into our paper on AI and ML way back in 2020 in the Indian Journal of Orthopedics, is pretty much descriptive of what is going to happen in the field of AI and ML. One of my favorite authors is Pedro Domingo, who wrote a book called The Master Algorithm. He wrote that you could say the God of Genesis himself is a programmer. Language, not manipulation, is the tool of creation. Words become worlds. Today, sitting on the couch with your laptop, you can be a God. And that's exactly what is happening with AI and ML. You don't need to know coding. You don't need to know programming, but you can still do a lot. Imagine a universe and make it real. The laws of physics are optional. And with that, let's get down to the beginnings. Turing in 1947 and in October 1950 wrote a paper called Computing Machinery and Intelligence, which is believed to be the very beginning of AI and ML. He created something called the imitation game, wherein one had to distinguish whether it was a computer or a human giving the response. And he also spoke of child programs, which are algorithms. But it is in 1955 when John McCarthy at Dartmouth actually set together a group of people, and the term artificial intelligence began to be coined. The official origin is authored by John McCarthy of Dartmouth, Marvin Minsky of Harvard, Nathaniel Rochester from IBM, and Claude Shannon from Bell Telephone Lab. These are the people who, in the year 1955, actually coined the term artificial intelligence. So it's not really that old. But if you look at the evolution of artificial intelligence, we go from reactive machines that learn from data and react to changes in an intelligent world to self-aware machines. Machines that, such as humans, seem to hold a sense of purpose. We haven't yet reached there. And we learn the purpose by observing the universe and body of knowledge around them. These can have opinion and cognitive biases just like human beings, but we haven't reached there yet. And as far as medicine is concerned, I don't believe that we will actually reach there. So what lies in between are limited memory machines that learn from experience and can perform both prediction and forecasting, which is achievable today, and machines with theory of mind that can understand underlying behavior and are capable of understanding and reacting to complex scenarios, which also we can achieve to some extent. Now, how do we define AI? It's the science and engineering that tries to make machine intelligent, to understand human language, to reach problems and goals as well as a human being, is what McCarthy said. John McCarthy back in 1955 said that. But what is mentioned in the Sanford 100-year report is a definition by Nielsen, which says that artificial intelligence is that activity devoted to making machines intelligent, and intelligence is that quality that enables an entity to function appropriately and with foresight in its environment. And intelligence is defined by McCarthy as the computational part of the ability to achieve goals in the world. And having said that, there are multiple domains to AI, which are heuristics, automated learning, computer vision, natural language processing, intelligent agents, and so on and so forth, right down to what we call large language models and ChatGPT today. So artificial intelligence is machine intelligence. It is study of intelligent agents that perceive the environment, takes action, maximizing its chances of successfully achieving its goals. There are a large number of types in that. And within this area lie a huge number of domains. You have machine learning, you have natural language processing, you have expert systems, you have computer vision, you have speech to text, text to speech, you have automated planning, robotics, all of which are relevant to our field of joint replacement. I call this augmented intelligence. It is something that has to augment us surgeons, become more intelligent, become more efficient, and deliver better results. Now, what is weak and strong AI? Weak AI is most of that AI which we see in practice. It's task-based, narrower, defined in its scope. Programs that behave as if they are thinking, but they're not really thinking. Now, strong or artificial general intelligence is something we have not really achieved as yet. Maybe we will achieve it in the future. But it is actually thinking, reasoning, and taking action. Still far from reality, not really much. So, algorithms. These are the building blocks of AI. Scientists make theories, engineers make devices, computer scientists make algorithms, which are both theories and devices, said Pedro Domingo, my favorite author again. So it is basically just a line of code, or 2 lines of code, or 3 lines of code, which is precisely written in a language that the computer understands. And more characteristically, Given an input, it must provide the desired output consistently. And it's not necessary that there should be one algorithm. There could be a series of algorithms working in sequence. There could be multiple algorithms executing multiple tasks in parallel. So multiple algorithms mostly work together in executing complex tasks. And the preferred method in artificial intelligence is clearly distinguished at all. There's a learning component and there is a performance component. The learning component is responsible for making improvement, and the performance component executes the action. Now, within this, an oft repeated term and alternatively repeated term is machine learning. It refers to the science of creating methods for machines to learn and apply analytical techniques. What we used to do in our research is logistical regression and multiple such methods. And when that is applied in a computational way, it constitutes machine learning. The synonyms are multiple. There's a huge number of synonyms. A few of them are mentioned here: pattern recognition, statistical modeling, data mining, knowledge discovery, predictive analytics, adaptive systems. Basically, it's just a set of systems that enable the AI through either inductive or deductive techniques. Now, there are multiple types of machine learning depending upon how you execute it. The most common method is supervised learning, in which there is an input and an output, a paired input and an output that is fed to the machine. This is the training data set. Now, having done that, there is a validation data set on which this algorithm is tested, and then eventually the model is deployed and it keeps learning with increased inputs to the algorithm. Now, the second is unsupervised, which by name means that unsupervised. We don't give an input and an output. The algorithm learns for itself. It categorizes, it classifies, and it understands for itself. It infers relationships on its own. And the third is semi-supervised or reinforcement learning, in which part of the data you will give, a small part of the data you will give a supervised learning. And on the basis of that, the algorithm will conduct an unsupervised learning. And that comes to be semi-supervised. And then there is a reward and punishment system. That is, if you run correctly, there is a reward and there is a punishment, or there is a negative effect or a negative score if you don't score correct, if you don't get the right inference, which is a reward and punishment kind of system, and hence termed as reinforcement learning. So if you look at this little flow chart, you see historical data with target. You know what you want to get. You have a data, you have input, you have output. You pre-process the data and you clean it. You remove the noise in that, and then distribute it into a training set, a validation set, and a test set. The training set is put through with the paired input-output data, whereas the validation set undergoes parameter tuning, and both of them are subjected to the algorithm. What happens here is then a model is created. The prediction result is created. There is a user feedback which goes back into the model. Once again, the data on the other side, the test set, which will be usually 10% to 20% of the total data set, is used to validate the whole thing. Once that has been done and the model is now ready for deployment, it can then ingest data in the real world data, which is pre-processed and ingested into the model, and which once again gives a prediction result, and then it goes into the feedback loop again. So this is a typical feedback loop for a supervised learning. Now, in unsupervised learning, the input data is raw. We don't know what we are going to be getting out of it. But algorithm puts itself into this data, infers classification, infers relationships, and then gives an output after processing the data. So this is what is typically known as deep learning, and some of the methods are clustering, anomaly detection, etc., etc. Semi-supervised has both labeled and unlabeled data. Labeled data is the supervised portion. unlabeled data is the unsupervised portion. So especially when you're doing MRIs and CT scans, etc., a few labeled examples of images are then provided by the experts, and then the algorithm takes over. These are typically a kind of a semi-supervised deep learning approach, but they are very important. And today, as far as medical data is concerned, the semi-supervised learning has a great role to play. Now, coming down to deep learning, these are commonly known as ANN or artificial neural network. These are typically labeled, modeled on the basis of the human brain. So you have a layered organization of neurons, which are actually nodes within the network. So when they are layered, they are believed to mimic the human brain. Each layer has a weight. Only if that weight is, say the weight is 0 or 1. If the weight is 1, it proceeds to the next layer. If the weight is 0, it does not proceed to the next layer. So simple yes or no questions could also power a artificial neural network. So typically the ANN network has an input layer, and then in between there will be multiple intermediate layers, and finally an output layer. What commonly you encounter are recurrent neural networks and convolutional neural networks. And they are pretty much useful when especially you have multimodal data and you have large volumes of data like EMR and EHR data and noisy data like sensor signals, microphone signals, or even like, say, thinking out loud, the hammering sound of a THR. There's a paper on that too, that, neural network was used to analyze the hammering sound that comes when you hammer your femoral prosthesis in and predict a fracture. The pipeline I already spoke to you about, but it's worthwhile just reiterating a little bit. So what happens to your data is that the data undergoes pre-processing. It's put through multiple computational filters, it is cleaned, and then it is prepared. Once it is prepared, it is either put through a deep learning pipeline where there is no classification, there is no labeling, or it is put through feature engineering, which are basically statistical properties, transformation, scaling, normalization, and then put into the machine learning pipeline. Once this feature engineering is done, as you see on your right, a cross-validation occurs on a training data set. Now, a training data set, you would typically split by using various methods, which like the split method or a k-fold method or a leave one out method. These are different methods in which you are categorizing your training data set into a training set, a validation set, and a test set. Then the accuracy is measured, and there are different metrics for that. We'll come to that shortly. Once the accuracy is satisfactory, you don't want to make any changes, then you put it on unseen data. This is data which is completely out of your test and training and validation set. And finally, the accuracy is measured. Did somebody say something? No, okay. So if the accuracy measurement is carried out using the S-score or the area under the curve for an ROC or a utility function, either it goes back into the loop to increase the efficiency of the algorithm, or the model is finally deployed in the real world. So this is typically the method by which most machine learning pipelines are developed. Now, some terms that are used when you read papers on AI and ML, which you are reading more and more nowadays, is sensitivity, which is the true positive rate, specificity, which is the true negative rate, the S-score, which is the harmonic mean of sensitivity and specificity, usually ranging 0 to 1, and the area under curve of the receiver operating curve, which is a measure of how well the algorithm can measure between classes. It's a bit too much to describe each of these, but I'm mentioning this because you will definitely come across these terms as in the various papers on AI and ML that you read. Now, the topic for today is mainly AI in arthroplasty. Now, it's important to understand the pros and cons of using artificial intelligence in healthcare. There are plenty of them. There are more cons than pros, I would say, but it is understood that the most important aspects are more or less within these categories. Is regulatory. There is a concept of software as a medical device, where a software which is not coupled to a medical device is then known as software as a medical device, and it needs to undergo a certain process of development and a certain process of maintenance. Now, the FDA and the European Union are all coming out with guidelines on this. Some guidelines are already in place. And most of these machine learning algorithms which get deployed in the real world, independent of a medical physical device. I'm talking of algorithms which are not part of robots, which are not part of things. Say you have a predictive algorithm which you are going to deploy to predict your metrics in arthroplasty. Now, these kind of softwares will need to be certified by the FDA, and you will need to maintain the certification by certain method. There are ethical and medical legal questions. Most important question is that you deploy an AI model and then you make a decision. Who takes the responsibility? Is it the manufacturer of the AI model, the one who devised the AI model, or is it you who deployed the model and made the decision? There is also a distributional shift that the same AI model may not be generalizable across population. It may not be universally applicable across populations. That is because when the algorithm was made, probably there was a lack of appropriate data, or probably the sampling was inadequate or too narrow, or there was too much of overfitting of data, underrepresentation of populations. And it's always known that there's been this word called black box decision making, especially with deep learning algorithms, where you do not know how the algorithm makes the decision. When you as a doctor take a decision, as a surgeon take a decision, you always know how you're taking a decision. You have certain evidence, you have certain intuitive understanding of the problem, you have certain experience behind you, and then it is a step-by-step approach to taking a decision, which you can justify in front of a court of law. But that is lacking, especially with the black box decision-making process. We are trying to surmount this problem by using something known as explainable artificial intelligence, but still a lot of work needs to be done on that side. If you look very broadly into the aspects of healthcare, you can look at healthcare administration, clinical decision support, patient monitoring, and healthcare intervention. This is where AI is at a very, very high level making an impact. And if you see the evolution of digital care delivery, it is more or less the basis of that are our AI and ML algorithms. Take a look at this figure from Gartner, where you're seeing this entire spectrum of digital care or digital care delivery, as you may want to call it, right from care management, wellness, investigation, there is diagnostics, self-monitoring, some diagnostics and treatment. So you can see that at every aspect of this, here you see algorithmic medicine, here you see AI-based imaging interpretation, you see precision medicine here, you see telehealth here, virtual health assistance here, predictive analytics here. So AI is sort of powering the new revolution in healthcare. And it's so much so the case with arthroplasty too. And if you look at the applications of AI in arthroplasty, there are plenty of them. There's a few of them listed here, from imaging to implant design to predictive analytics to robotics to pre-op planning to rehabilitation to post-op follow-ups and risk assessment and optimization. And when we wrote a paper back in 2019-20, it was published online in 2019 and assigned to an issue in 2020 on artificial intelligence and machine learning being a new disruptive force in orthopedics. I wrote it along with a couple of colleagues from my organization. I work for a technology organization. And when we wrote this paper, there was hardly any literature on the subject out there. But today, there's a profusion of literature. You search for AI and arthroplasty and you're filled up with pages and pages of results. So a few samples you can see on your screen now. And they pretty much cover every aspect of the discipline, whether it be medical imaging, post-operative care, or surgical technique. And I would be referring to some of these papers, especially those which you can see on your right from the journal Arthroplasty, as I take you through some of the possible applications of artificial intelligence and machine learning in the field of knee arthroplasty. And I come back to this slide, which I really like because it sort of sums up everything. It sums up everything that you can do with AI and ML, which means imaging-based or diagnostic applications, medical or adverse event prediction, hospital or administrative support, and finally surgical planning and surgical performance. In the preoperative area, one of the most important areas has been to diagnose osteoarthritis. Now, you might wonder why we need to diagnose osteoarthritis when you can easily make it out on a standard X-ray, but there is a lot of work, and I myself have a paper on the subject of using deep learning algorithms in diagnosing OA and classifying OA. And also there is the prediction of future requirement of a TKA from an X-ray analysis. So plenty of papers based on the, mostly data from the Osteoarthritis Initiative. There is also papers on HKA angle estimation. There are the American Academy of Orthopedic Surgeons has got an algorithm to streamline and standardize patient selection on basis of medical history and symptom severity. And this is one of the fundamental criteria. How do you select a patient? We don't have that answer yet. We don't have the classical, final answer here that this is the best way to select a patient. Because getting the patient right is the first step in getting the arthroplasty right. And that is the first step in getting the satisfaction index right. Another area which has been very prominently explored is implant size prediction and implant identification. Now, implant size prediction, despite digital templating tools, remains a challenge. And with the inventory increasing more and more with the increase in modularity, implant size prediction has come to be an area which has been extensively explored but not really utilized. Kunz et al. Have got a tool up there on the web where you can input some basic parameters such as BMI, age, sex, and then get a tentative implant size. Now, this would matter to me because this was actually based on a single implant data set. But most manufacturers have different in their implant sizes. And therefore, this would be a challenge in the near future because every implant manufacturer has their own physiology and their own fundamentals in determining implant size. So you cannot have a single algorithm for all the manufacturers. We actually wrote about this a couple of months ago in the Indian Journal of Orthopedics, where we proposed that there should be some kind of an open source philosophy and a common implant sizing across the implant manufacturers. But I don't think that's going to happen in the near future. Surgical training is an area which is very important, and I think the pandemic taught us that when people were kept away from the knives and using AR, VR, simulators, which are powered by artificial intelligence and machine learning algorithms, surgical training is definitely going to take a lot of support from these virtual, non-judgmental, anytime, anywhere training modalities. Pre-optimization and prediction of length of stay has been extensively explored, but to the best of my knowledge, not implemented. It is still in research. You can use basic factors such as age, sex, comorbidities, previous surgeries, and such BMI and such other factors together, and then predict the length of stay. And that has been explored a lot, especially from the Cleveland Clinic, but there has not been, I am not aware at least, of these being used in day-to-day practice. Preoperatively, most of your templating software is powered by artificial intelligence, especially the segmentation and morphing algorithms. During surgery, robotics and navigation obviously heavily rely on AI and ML algorithms. And now there is a push towards augmented reality based on algorithms, which are essentially image free and which use a head mounted viewer for the surgeon. Image free procedures also have this morphed model, which has been devised out of putting an algorithm across thousands of CT scans. Ligament balancing and tissue sparing is another area where these algorithms are used, and as of course, implant positioning and real-time alignment. I like this figure from Bilateral et al., which is a 2022 from the journal Arthroplasty, which that's why I decided to just put it up here, which tends to summarize what happens in the preoperative and the intraoperative parts and where do the algorithms play. If you look at the preoperative aspects, we have decision aid, that is clinical decision making, surgical planning, using 3D models, implant sizing, implant position, ligament balancing, and all that. And for the surgeons, education and training. These two aspects of it are significant areas in the preoperative area. But if you look at the intraoperative side, the shift is more towards the data oriented. Intraoperative data such as image-based 3D model, AR, MR, assistive technologies like robotics, computer-assisted surgery, sensors, etc. Implant position alignment, ligament balancing, soft tissue and bone preservation, and big data. Now, all of this makes more sense if you look at it. Just give me a moment. When I finish the post-operative, then I will try to see where this all comes together from a similar figure from Bilateral et al. In the post-operative phase, patient monitoring and rehabilitation is extremely important, especially with wearables and ML-based tools, which are varying in their capabilities. Now, there are video-based algorithms, there are audio-based algorithms, there are text-based algorithms, there are speech-based algorithms, which are being used to monitor patients, because as we have learned, the less time spent in the hospital, the better. So to support that, we need various technologies, and these are powered by AI. And also there are predictive models which examine how variables such as patient-specific attributes, functional scores, preoperative pain, comorbidities, psychological features, socioeconomic indicators, perioperative recovery location, whether it's in the hospital, it's in a recovery home, or is it at home itself, or it's in a rehabilitation center. All of these influence clinical outcomes. So there are algorithms which are practically tackling everything. So where it all comes together, as Bilateral has very nicely put this together, is an interconnecting feedback loop, where there is data from the preoperative area put through the AI-based tools, robotic surgery put through the AI-based tools, and post-operative data, which is collected from wearables and mobile phones, put to the AI-based tools to optimize patient management, maximize your surgical result, minimize your time in hospital, minimize the comorbidities, improve the patient-reported outcomes. So this is how it looks back. A little later, I'll show you something which resembles this from our work. So there are specific areas of research, predictive being predicting component size, length of stay and cost, transfusion after TK, patient dissatisfaction after TK, wearable, an ML platform was, explored by Ram Kumar from the Cleveland Clinic, where they had this wearable and ML-based platform then they also had a knee sleeve with sensors to monitor the range of motion and activity. And so this whole thing was found to be very useful. The prediction of early revision. There are factors which can be found, and deep learning can actually tell you which are these important factors which predict early revision. A very interesting paper from Lamprex talks about reducing the number of iterations. As we know, the component manufacturer comes with the manufacturer's preoperative plans, which are then modified by the surgeon as the surgeon modified plans, and those are sent back for your PSIs. I know Professor Mahmoud will be speaking on PSIs, but a very interesting algorithm devised by Lamprex sought to reduce the number of iterations required to get the correct preoperative surgeon-specific as well as patient-specific plan. So AI can be really used to smoothen the processes, to smoothen the steps and to reduce the time, as well as the last one here, which I've written, is preoperative prediction of value metrics, which is the HEOR, that is Health Economics and Outcomes Research, right down to a patient-specific payment model, or PSPM. Again, groundbreaking research published in Journal of Arthroplasty by Ramkumar et al. From Cleveland Clinic. On the imaging side, we have automated detection and grading of osteoarthritis, which even we have worked upon. Automatic detection of knee implants and distinguishing between UK and TKA, published papers on that. As many as 9 different types of knee implants were distinguished in various papers published over the last 2 to 3 years. Automated sizing is becoming a reality. And of course, in the long run, what we need is the detection of loosening of the implant, on which there is some work going on, including from our side. So this is some of the papers that we have published on AI and ML. I work with my company, its research wing, and some of the musculoskeletal research work is shown here. We have done some automated landmark recognition, and we've done used the Apple Watch to detect shoulder movement for shoulder arthroplasty. We've predicted sepsis using continuous and categorical variables. We've also used data from the Grand Challenge. That is the first sensor-enabled knees. The data from them was collected on treadmill and was then released as serial challenges over 5 years. And this was known as Grand Challenges. So we also worked on predicting knee kinematics using the Grand Challenge data, and we have published the same. And we've done quite a bit of work on range of motion using various methods. We've also worked on MRI-based knee disorder diagnosis, as well as diagnosis of osteoarthritis of the knee. Much of this work is from within my company and some from outside my company. And we believe that digital health is a major area. So within my company, we have been reimagining patient experience from the point of view of the patient, and making things easier for recovery following joint replacement. You can find this paper within the tcs.com website. If you simply type down this name and type tcs.com, you will get this white paper. We used a service design approach, a design thinking approach. We used an empathy map. We used the caretakers, the patients, the hospitals. Everybody comes within the ambit of a service provider, whereas the patient is a service user. And if you remember what I told you earlier from that map from Battalier et al., this is what we published, which is very similar, and it was published much before Battalier et al. On our website, is that we need algorithms at the base, but there are multiple factors which come into play if you have to design a solution for joint replacement. And this is our vision, wherein sensing behavior, sensing gait, sensing range of motion, getting physicians, orthopedic specialists, patient education portals, everything together is what we believe is the future of comprehensive rehabilitation. And I'd like to finish in the next 2 slides. And what Satya Nadella spoke about on Slack long ago, not very long ago, some years ago, one of the principles for AI in the real world, that AI must be designed to assist humanity. It must be transparent. One must know how it works, and men must know about the machine's ethics and design going hand in hand. You must maximize the effectiveness without destroying the dignity of people. It must be designed for privacy. You cannot let loose AI and compromise privacy. There must be algorithmic responsibility so that the human always has an ability to undo unintended damage. So much so important for us. This is not written from point of view of medicine, but every point is important from the point of medicine. It must avoid bias. One needs to ensure proper representative research to avoid bias. And what do humans need to stay relevant in the age of AI? From the very same talk by Satya Nadella, humans need empathy, which cannot be replicated in machines. Humans need education. You need knowledge and skills to implement new technologies on a large scale. It will mean a change in the basic medical curriculum, which needs to incorporate the knowledge of using algorithms in the practice. Creativity. If we don't have creativity, how will algorithms enhance our capabilities? We need the creativity to devise algorithms to enhance our capability. And lastly, and not the least, judgment and responsibility to accept that a decision made by a machine still means that a human is ultimately responsible. And on that note, I thank you for your attention and I conclude my talk for the day.
Thank you so much, Professor Murali, for this very interesting talk. Thank you so much, sir, for being with us.
Thank you. Thank you for your attention, sir.
You are the moderator of this session. This part of the session, please.
Thank you, Murali. Thank you very much for the excellent presentation. If I may ask a few questions on the AI and applicability of AI in arthroplasty, what do you think is the learning curve for this for surgeons? And also the data privacy and security. Who owns the data you take from or
see every algorithm or every data that is being used is governed by the HIPAA Act. So unless you follow those guidelines, you cannot use data. Even if my Apple Watch is collecting my health data, it needs to seek my permission to use it. It needs to seek my permission. Though we pay scant attention to all of these, our health data belongs to us only, unless we give explicit permission for somebody else to use it. And these protocols are followed throughout the use of and development of algorithms and deployment of algorithms. So there's no question about that. And one of the biggest fears, I intentionally did not touch on the controversial topic of generative AI and large language models and ChatGPT, which is slowly but surely taking the world by storm since February of this year when it was first launched. But I'm still observing the field. And before I observe the field, I do not want to put my opinions before this august audience.
Of course, data, when you're collecting data, we need the permission from the surgeons and the patients for doing research. But what AI does is it changes data or it analyzes data and makes decisions on the part of the surgeons. So on those decisions, who would be responsible? Does a surgeon?
The surgeon has to be responsible. The surgeon
or
is
the
responsible.
company? Okay.
That's exactly one of the controversies which I raised. Who's going to be responsible? The medical legal side of it. We don't, unfortunately, have much clarity on the subject. But I believe as clinicians and surgeons, and like I used the word augmented intelligence, we use these tools to improve our capabilities. But the decision and the responsibility ultimately remains ours. If a robot, there was this little forward going on WhatsApp that a robot went amok and killed a patient somewhere, while the surgeon was having coffee when the robot was operating. Now, This is nonsense. I mean, you cannot do this kind of thing. I don't know if it's true or not. Most of these are just, cooked up news. But what I'm trying to say is that ultimately we are responsible for our actions. The tools and the methods we use to take those actions is up to us. But we are responsible for whatever we do. And that should never change, because that is what we are as surgeons.
So one basic question is, AI is the software part, isn't it?
Yeah.
Robotics is the hardware part of the computer.
Yes.
And AI can introduce bias in its assessment and algorithms, isn't it? It depends on what you expose the computer to.
Yes. It's a standard statement, GIGO, garbage in, garbage out. So you put in garbage, you get out garbage. So you need to be exceptionally careful when you deploy this algorithm and the kind of data you expose the algorithms to. So I am myself right now sitting and annotating as many as 1,800 X-rays personally. And I'm scared that I might make one wrong annotation and things might go wrong. But then that's the way it is. So you need to take due diligence, is the word that we use, due diligence, and then deploy these algorithms in the real world. When you deploy the algorithms in the real world, the truth comes out.
So, in fact, the control is actually taken away from the surgeon because he's the end user, and he'll not be in control of what is fed into the system, isn't it? Somebody else feeds into the...
No, I disagree. Okay. Because the surgeon is never out of control. Because the surgeon has made the preoperative plan, he's fed the preoperative plan into the computer, he's verified the preoperative plan, and then he is guiding the robot through each step of the surgical procedure. So the surgeon is in control, but he has to feel that he's in control, and he has to behave as if he's in control. He cannot not behave that way. Actually speaking, all of the robots in orthopedics are not automatic robots, except for the QREX, which completes all the cuts, but the rest of them are all semi-automated. So semi-supervised, wherein we control what happens, but the computer prevents us from making an error by putting in something known as boundary limitation. In that boundary limitation, you are prevented from cutting outside the levels of safety, and you are guided in your ligamental balancing. So ultimately, yes, you are under control, and you will always be in control, and that should always be the case.
Yes, Srinivas, go ahead.
Please.
No, go ahead first. Yeah, I will call it.
What I was going to say was we had the robotics in arthroplasty talk last week, and this is what we were told. There are 3 different types of robots: semi-automatic, automatic, and so in arthroplasty it's mainly semi-automatic, whereas in
semi-automatic,
automatic, where the surgeon is not involved in general surgery.
No. In general surgery, mostly you have master slaves. Master slaves or the Da Vinci is where the most of the robots are master slaves. So we don't really have automated robots yet, but the general surgical robots are what we call master slave, in which there are 2 things that happen. One, the surgeon is ergonomic, he's sitting at a master console, and there are 2 things that happen. That is, your involuntary tremor is suppressed and your voluntary actions are amplified. That is, your finesse of your actions is amplified by a 6 to 8 degree freedom endo wrist. That's what happens within the Da Vinci. And your voluntary tremors are suppressed so that you become more precise in your sleep. And number 3, you get an immersive vision. You get immersive vision, which is 3-dimensional, and therefore you can actually see what's happening. So these are the 3 things that happen in most of the general surgical robots.
Professor Hafez, please.
Yes, I mean, first, I want to thank Prof. Murali for this very informative talk, a lot of information and very, very useful to come from an orthopedic surgeon or professor. I have a comment and a question. The comment first regarding your last question about the robotic. I mean, as Prof. Murali rightly said, all the robots in surgery are different from orthopedic robots. Surgery, and what I meant by surgery here, general surgery, urology, cardio, gynae, obs and gynae, and all other surgical robots. They are master slave, where the surgeon are sitting in a console and is not at the operative site. The robot is operating. And while the orthopedic robot, the orthopedic surgeon is standing by the robot, and there is active control. So it is to some extent it is constrained, and this is a difference. That's why we cannot use Da Vinci robot or any other surgical robots in orthopedics. But history told us that robotics started in orthopedics actually very early in 1992 in clinical orthopedics related research. This was the first publication about orthopedic robodoc. Doing hip replacement. So we started really early, but because of the FDA and other problems, it did not materialize into routine practice or clinical practice until recently. This is my comment. Can I proceed with the question?
Yes, sir. Please.
Okay. Regarding the AI, I mean, I started working on robotics from 1998. And at that time, I was fascinated by AI, but I didn't go into depth with that. But at the time, mainly was for diagnostic. And now you can see it is everywhere. Okay. So do you see the future? Is there going to be any rule for the AI in diagnostic more than therapeutic or surgical action? That's one question. My second question is regarding the different types of technology. We have robotics, we have navigation, we have PSI and 3D printing technology, we have virtual reality, augmented reality, and all other types of mixed reality and different things, and AI. And AI is going into every one of these. But do you think in future, either near or far future, they're going to be a merge of these technologies together to come up with something that's going to be really more practical, more usable, user-friendly, cost-effective, so that it can be a standard? Because none of all these technologies is a standard right now.
Yes, to answer your second question first, I think that's precisely what we all want, right? We want something that is usable, and coming from similar countries, our countries are very similar. You want something that is cost effective, something that is occupying less space in the theater, something that makes it easier for you to use. Now, we're talking about AR and VR. Using the headset is not a piece of cake. You get headaches, you get giddiness, you get loss of time, and you get disorientation of time and space. Which will be the right one, we do not know. But like you so very rightly said, from the 90s when Robodoc was first introduced, I saw my first Robodoc hip replacement in 2003. So that's when I saw the first one. And that time the surgeon from the Army Referral Institute in New Delhi said that it causes too much blood loss. After that conference, I don't think he ever did Robodoc. But so it's now suddenly, just 2 years ago when I was watching the CCGR, robotics was query. But last year CCGR, it was all over the place. So it's like I don't know, was it Leo Whiteside who said that? I don't remember. But the pendulum of fashion swings from side to side.
Yes.
So absolutely. That's what's happening. That's exactly what's happening.
Yeah.
And but so this is where it is. But the algorithms, to answer your first question, I think it was about algorithms, right? Yeah, first question, if I'm right, yeah.
About the diagnostic and therapeutic.
Yeah, diagnostic therapeutic.
If we can divide it this way.
I would like to think that diagnostic would take precedence over therapeutic. And there are reasons for this. For example, let's say in the United States of America, mammograms are mandated for every woman above the age of 40 every year. The sheer volume of mammograms to be interpreted makes it extremely difficult for a radiologist to be able to do that. Now, these are the areas where it will come in. Now, let's look at orthopedics. Let's look at, say, distinguishing a cartilage tumor between benign and malignant, chondroma versus chondrosarcoma. Even the most seasoned pathologists can often struggle to distinguish between a chondroma and a chondrosarcoma. So diagnostic is an area which is definitely very important. Therapeutically, I see predictive analytics coming into the picture, like this prediction of length of stay. Those patients, like we get an insurance approval and they stay 2 days extra, we don't get the money for that patient. If at least you have got some theory, something to back you up that this patient might stay longer. Those things will definitely come up more than actual clinical decision support. I honestly don't know how much it will take off because the fiasco of IBM Watson is still very close by. So we don't know really where we will go with clinical decision making, but diagnostics definitely, and improving process definitely. Process, supply chain or optimization, size prediction, inventory optimization. These are areas where we definitely will see AI and ML coming in. I hope that answers the question.
Yes, thank you so much.
Yeah, thank you, sir.
Who regulates AI, in use of AI and robotics in orthopedics in India?
Nobody. Not yet, at least. Not yet, at least. Not yet, but CDSU the current regulatory authority has not yet come up with regulatory guidelines. The CDSU, what we call it, but we anticipate that they will come up because India has a very robust digital transformation program, and we will expect that guidelines for this will also come in. So, but at this point, I'm not aware of any regulations within the country.
I think for research, ICMR has given out some guidelines, I think.
Yeah.
And what about the impact on healthcare workforce? Will the orthopedic surgeons lose their jobs because of...
Never. We will always be there for carpenters of the human. I call ourselves carpenters of the human body, and nobody can replace us. I'm very clear about that.
Yeah. We are in control.
Yes, sir. We are in control. Absolutely.
Professor El-ashhab, do you have any questions?
I think we need more regulations, sir, regarding this the performance of any surgical interference using navigation, using robotics. I think we need more and more regulations. Maybe these regulations may be regulated by the Egyptian Orthopedic Association, the Indian Orthopedic Association, the authorities there, the medical authorities there, but we need it to be regulated, I think so.
Right, sir. You are absolutely right. We need to be the movers and shakers in getting the regulations done. Because unless we do, our patients won't be safe.
Also, given that there are so many robotic units being implemented even in private practice nowadays, the numbers are going to increase in the future.
Yes. Yeah,
there was
I
one in
believe
Bombay,
that.
Sir, in about 2-3 years ago, 2019, I attended the Orthopedic Surgery Society of India or something, some conference in Pune. That time there was one robot in Bombay. As of now, there must be dozens of them now. In just 3 years' time, the number has proliferated multiple times. And every day I'm hearing somebody or the other has bought a robot. And in fact, when I was
spreading like a fire now.
Yeah, it is selling like anything.
In the Gulf area, it's really spreading fast.
Yes, and here I was speaking in a forum on technique and technologies in joint replacement in April of this year. There were 4 robots in that hall. We have managed to get 4 different robots in the hall for demonstration at one place in one hospital. So, I mean, the need and the desire to be one up on the next person is so immense that people are jumping in for technology. But I sincerely pray that people understand the technology and use it correctly. That's all.
But currently, if you look at the evidence, do you think there is a difference between manual?
There's no evidence. There's just one paper in the JBJS. Okay. Now, this JBJS paper analyzed the inflammatory markers in drain fluid following conventional and robotic assisted knee arthroplasty. And this inflammatory marker in the robotic assisted knee arthroplasty is significantly lesser. Now, despite the fact that most people are talking about the bony preparation part of robotics, I believe the more important part of robotic surgery, which Professor Mohamed will definitely agree, is decreasing the need for soft tissue release. The need for soft tissue release, right, sir?
Definitely.
Yes. So the need
I now lost the skills of soft tissue release. I don't do it. Rarely, honestly.
Really nice. Really nice.
Yes, surgeons using conventional technique. I mean, they can't believe this statement when I say it. But the need for soft tissue release is getting less and less.
Exactly. So that's one of the major advantages. And plus the quantification of ligament balance is important because for our studies and research, the quantification is important. Though I believe there's only one robot now, which is, I don't remember the name of the robot, which works on robotic ligament balancing. There's just one in the market right now, which really does ligamental balancing. But I think we are in for good times. I think eventually all of us will have to learn robotics. There's no way that we can get out of it. But we should be conversant, and we should teach our students to be conversant of conventional techniques so that you can have a way out if you're in trouble.
There's also the talk about loss of clinical skills when robot comes in. So how true do you think this is?
Well, when navigation first came in, they used to say that, when navigation first came in, people used to say that navigation cannot make a bad surgeon good. Navigation can make a good surgeon better and an excellent surgeon even better.
Yes, I agree.
Similar is the case with robotics. Unless you know your basics, you can't do it. I don't think it makes sense. It's not that you don't know how to do an arthroplasty. You want to improve your results, adopt robotics. But don't make robotics your go-to for just getting your results. It doesn't work that way. You have to understand the principles behind, the basics behind, the fundamental principles. Otherwise, it doesn't make sense. At least to me, it doesn't make sense.
Right.
Sir, you agree, sir? You are an expert in robotics, Professor Mohamed. Professor Mohamed, do you agree to me?
Yes, sir. I want to ask a question, sir, please.
Yeah.
What about the educational progress in the robotic surgery? Do you think, sir, that the traditional way of surgery is it more beneficial for the junior surgeons or using the robotic assisted surgery? What's regarding?
I had a question I asked one of my spine colleagues.
Yes.
I asked him, do your fellows know how to pass a pedicle screw without navigation? Because I learned to put a pedicle screw without x-rays, without a CR. So that's how I learned, simply by the sound of the K wire going into the pedicle. But when I told, he said, no, that time is gone. Now they all learn on navigation, and when they get into practice, they get the navigation system, or they work in a place with a navigation system. That is one thing. But I do believe, as a teacher and as a senior surgeon, I believe that the conventional methods of teaching should not go away, and you should not be dependent on technology right from your learning years. I'm sure you will also agree to that.
So it's a question from me. I'm not accustomed with the robotic surgery, but Dr. Hafez is highly specialized in it. By time, if I use robotic surgery or navigation or assisted navigation or virtual reality, do I lose my clinical sense?
I don't think so.
No,
you improve your clinical sense because all these tools are, we call it enabling tools. It gives you visibility. It gives you more information. Like, for example, when I do the PSI and I do a preoperative planning and I have 3D view of the knee from everywhere. This is something I cannot see during the surgery. So it is giving me more information. It makes me more aware. So I'm not losing the skills. I don't look that old, but I work at the start in orthopedics. So in my hospital, we did not have C-arm. University hospital, but it wasn't having C-arm. C-arm was just introduced at that time. So we used to do like a DHS. We put the wire looking at landmarks and put the wire and take X-ray view, and so on. If the wire is right in the right place, then we carry on. So do you think that when the C-arm came as a technology, do you think we lost the skill of using these landmarks? Probably, but it became not useful.
Thank you, sir. Yes.
But we did not use the surgical skills itself.
I honestly speaking, when I started using the C-arm to implant a pedicle screw, my accuracy became slightly less than when I was using only X-rays or no X-rays. I felt I was better before that. That's a very subjective statement. It's not an objective statement. I don't have data to prove that.
One major drawback is the cost. Do you think as more people start using it, the cost will be coming down?
No, they are coming up with new payment ways. They are coming up with different models in which the implant is locked to the device, or it is locked to an X number of surgeries. So very soon you might have trucks carrying the robot from hospital to hospital.
Yeah.
So you don't know what is going to happen, but they are coming up with innovative. The capital cost won't go down, because the capital cost, what is happening is the capital cost I do know that the Cori or the Navio has gone down in cost by 50% in India in the recent past from the introductory price. But the thing that is important is that these involve a significant cost in development, and they recover that cost from the cost of the capital equipment. But now, most of them, especially even in spine navigation as well as in joint, they are coupling it with the use of the proprietary implant. And so at least 50% of the costs are offset. So there are ways and means of getting around the costs.
Right.
Yes, it will come down, the cost. If you look at the mobile phones now and car phones, when car phones started, it was too expensive. And also mobile phone when it started, and then gradually get better technology with less cost.
Right. If we don't have any further questions, we'll move on to the next talk, sir. We can talk.
Thank you so much for an interesting talk about a very interesting topic. Thank you so much, sir. Our next speaker will be Professor Mahmoud Hafez. Professor Mahmoud Hafez is a consultant orthopedic surgery in Egypt and UK. He's a professor and head of the Orthopedic Department, October 6 University in Cairo, Egypt. He's an honorary visiting professor in Cardiff University in UK. He's an executive committee member of the Computerized Assisted Orthopedic Surgery and IFIA International Societies, and he's SICOT National delegate. So all of us will meet him in the next SICOT meeting in Egypt. I hope to see you in Cairo in 20 of November. Professor Mahmoud will speak about bilateral simultaneous tooth and replacement using PSI, patient-specific instrument technology. Please, sir.
Thank you so much for the invitation, and thanks for this introduction. This is my declaration. This slide is really showing you what we get. This is like the bread and butter for arthroplasty surgeons in Egypt, and I'm sure it's in India and many other similar countries. We have really different type of patients. I practice between here and UK, and I never see these patients in UK. Okay, you get the bilaterality, you get the severity, you get late presentation. Also, the incidence of osteoarthritis is quite high. And then you get with the deformity, the complexity, the comorbidities. We get different circumstances with regards to the economy, either the patient paying or either the government paying, wherever. Still, there is a struggle. The psychology of the patient is scared from having surgery. That's why they leave it late. Their habits, they want to have bilateral knee, with that for this severe deformity, and they wanted to pray and sit on the ground, they cross legs and squatting positions. So the demands are different, habits are different. So it is a problem. So when I came back to Egypt after being in UK, US, and Canada, and started doing knee replacement here, I got many complaints from having unilateral. To me, it looks perfect, but patient is not happy. Okay, the one of the patient was really not happy because his leg is becoming longer. He said, "You made my leg longer. The other one is short." I said, "Yes, the other one is a problem. It's not the one I did. That when you have the second one, it will become longer, and then they will be equal." So with all these problems, I found that bilateral simultaneous TKE is a solution. Okay, you look at the three problems there with the unilateral, as I mentioned. But we have another problem. If we're going to do a bilateral simultaneous, how can we do it? We have to look at the criteria. If you look at the literature, this is a 4 criteria which is listed in all the literature. Unfortunately, this literature missed one very important criteria, which is deformity. And I assume that everyone who's listing these 4 criteria is talking about or is addressing a primary straightforward knee replacement, not bilateral complex primary. So when you talk about straightforward primary, yes, you can apply these criteria, but if you're talking about criteria for complex bilateral, then it is a different story. Okay, so most of our patients, unfortunately, they don't fit this criteria. The age, they may be less than 70, But the 70-year-old patients that I see in UK who walks about 5 miles is different from the 60-year-old lady in Egypt who doesn't walk that much. Okay, probably they walk indoors. And then the cardiac disease, diabetes, and the body mass index. So this means that if these criteria are not fulfilled, then you will hardly find a case that can fit a bilateral knee replacement with the conventional techniques. So what will happen if you do bilateral and you're not either fulfilling the criteria or having a problem? There are two problems that scare every surgeon from doing bilateral. One of them is infection, and the second one is mortality. Okay, so let us talk first about morbidity or infection. If you have infection in a bilateral, whether this bilateral is done simultaneously or whether it's done one by one, or even if you have a unilateral, the problem with infection here is that amputation could be the last result for persistent, irresistible, or untreatable infection. And above knee amputation is very, very bad. Below knee amputation has got good function, no problem with it. It has indications and patients are happy. But above knee amputation is a completely different story. So if you have a bilateral above knee amputation, I think the patient will say, I will die better than having this operation. So how can we control infection in order to do bilateral? Here is just, as you can see, this drawing here, just showing, the standard criteria for OR. And one of it is laminar flow. And laminar flow, because of the cost, it may not be available in every theater. I mean, even when I work in UK, laminar flow is not in every orthopedic theater. You usually just have like half of the theaters with a laminar flow and the other half where they do the trauma, they don't have laminar flow. So when we don't have laminar flow and we have an instrumentation system which comes from the company, it's not stored in the hospital, then this is another problem with being decent instruments and being, it is not under the laminar flow. And if you're doing a bilateral, even if you have two sets of instruments, it's still a problem. The second thing that scares every surgeon is mortality. Mortality here does not come from PE or DVT, as many people think. It comes from fat embolism. Fat embolism is a thing which can kill the patient on the table or on the first day. Okay, so that fat embolism, we know from literature that if you do bilateral, the fat embolism risk can go up to 16%. But also we know from the literature for trauma that if you do reaming for example, bilateral femoral fracture, that fat embolism risk can go up to 41%. Okay? So the disaster happens is when a surgeon decides to do bilateral knee replacement for a patient with either severe deformity, with osteoporosis, with obesity, and in this case, stem is indicated. So when you use a bilateral tibial stem, then in this case, even if you are using extramedullary guide for a tibia as a routine, you're going to perforate and ream the tibial medullary canal. And also you have to go into the femoral medullary canal, even if you're not putting a stem, because this is a way we cannot use extramedullary femoral. We have to use intramedullary. So this means that you are going through 4 medullary canals. 4 medullary canals is a disaster. And what you expect from here is mortality. So please don't do it. And if you're going to do it, or if you have to do it, then you have to use technology. Because I know that certain procedures now in orthopedics became mandatory to use the technology. So for example, if you're doing a pedicle screw for cervical spine, I think it became mandatory to use navigation or any computer-assisted tools. If you're doing a revision shoulder surgery, you have to use PSI technology or other tools. Otherwise, if any case happened, then it's going to be undefendable. So when we look at the conventional instrumentation system, which improved in 1970s, and that's what made knee replacement successful, they are great tools done and invented by senior and eminent surgeons and engineers who made this instrumentation system and made the knee replacement successful. But unfortunately, in spite of all the improved technology and the modernization and everything, these instrumentation systems are still the same. If you look at 1980s instrumentation system and nowadays instrumentation system, they are basically the same in spite of all modification. Even the modification, they made it even worse and more complex. So you can see on the right side all the problems that come with this instrumentation system. So when you decide to do bilateral, and you have to have two sets of instruments, and you have to really be careful because the traffic inside the operating room is one of the main factors behind infection. So when you have two sets, and if your operating room is not wide enough, then it's a problem. So even if you're doing a unilateral with this conventional instrument, still there are certain cases where you cannot do the knee replacement. For example, if you have extra-articular deformity, and you cannot go with the intramedullary rod, especially inside the femur, okay? And then if you have a retained metal, old plate and screws, or Sherman screws, or plates, that you cannot remove, that's another problem. If you have bilateral with severe articular deformities and having a stem in a tibia, for example, okay? If you have bleeding tendency and a hemophilia, and I had cases of hemophilia, and surprisingly, when I communicate with the hematologist advised me to do bilateral. And I said, why? Because of the preparation for hemophilia preoperatively and postoperatively and intraoperatively, and also the cost. So for many patients, especially who cannot afford, having the factor VIII and the plasma and all these sort of things, which are really expensive, then doing bilateral hemophilia is recommended by a hematologist more than by the surgeon. Medically unfit patients, and then you have difficult revision of tumors. All these will require technology. I didn't mention why technology is needed when you have hemophilia, just because you don't go into medullary canal, then you're reducing the risk of bleeding. Then in this case, it is good for hemophilia, okay? I mentioned that if you're doing a bilateral and you have to use a stem, then in this case, you use computer-assisted surgery. Unfortunately, robotics and navigation, although I'm fan of these and I believe that they have great role in orthopedics, but when we do bilateral knee replacement, there are many common drawbacks for robotics and navigation. As you can see, they are listed down there, that they will really make the case difficult, even for a unilateral knee. Although the robot that I'm presenting there is an old one, okay, and all the modern robots now, they are definitely much better, but still they have all these common drawbacks. So now we're coming to another technology called patient-specific instrument or templating, as I introduced, and this technology depends on 3D printing. So how it works? First of all, we have a CT scan for the patient. We get this CT scan inside the computer, and with this CT scan giving a 3D images of the knee, coronal, axial, and transverse, okay, coronal, sagittal, and axial. And with these planes, you can see the knee from everywhere. You can spot all the deformities, all the problems that you cannot see during surgery. And then software automatically will size the knee, as you can see here on step 2, will make the sizing automatically, will position the implant according to the mechanical axis. So it follows the mechanical axis. And after this complete simulation of the surgery, showing the cuts and the thickness of the cuts from the bone, from femur and tibia, then it develops automatically a template. that is specific for this patient. And this template is one for the femur, one for the tibia. They are based on the surface matching. So the femoral template will fit on the distal femur. So it usually get into one position, and once it got into this position, you fix it by wire, and then that's it. You are perpendicular on the mechanical axis, and the same for the tibia. So you have first these templates virtually inside the computer, and then we have to take them to theater. So how can we take these virtual ones to theater? By 3D printing. So these are usually stored in a file called STL format and send. It is a small file. It can be sent by email or even WhatsApp, and then you can get it into the 3D printer, print the templates in a material which is biocompatible, some of them even biodegradable, so there is no risk of debris. And these materials are good enough to withstand the machinery actions for the knee replacement. So you position them after sterilization, you position them one on the femur and one on the tibia. Definitely is one by one. You cannot position both at the same time. Okay, so you do the femur first, we make the cuts, and then we position the tibial one, and you do the cuts through the slits present in the these templates or custom-made cutting guides after accurate positioning. So the main advantage of that is that you eliminate the perforation of the medullary canal or the penetration that can cause fat embolism. So here, the risk of fat embolism, if you don't go inside the medullary canal, is almost zero, okay? And you eliminate the use of all these conventional instruments and just only focusing on only very small supporting instruments, in addition to the hammer, which is already in every orthopedic tray, okay? And in addition to just the trial templates or the trial implant, which he can also use from the same material that you're using the guide. Okay, so here you can see the guide in white and the templates here in black. Okay, here is a case, for example, of bilateral. You can see the sets of instruments for the PSI. Okay, in comparison to the conventional instrument, which is huge, as you can see here. We just took this photo just for comparison because in certain hospital, we have to open the conventional instrumentation or to have it just like a standby. One other problem in developing countries is that most of the hospitals, they don't stock implants. So the implants, as well as the instruments, will come to the hospital by the distributor, the day before surgery or the same day of surgery. So with all these implants stored in a bag like this, and this bag goes from a hospital to another hospital, it's not transmitting COVID here, but it is a source of infection. So don't put these implants or this bag inside your operating room. Okay, because this is a big source of infection. Please keep it outside, okay? But you're having another problem that you're spending 15 minutes or longer to measure the tibia and femur, and then making a decision which size you're going to use and asking whoever, the nurse or the medical rep or the company rep to get these implants. While when we do PSI, as you can see here on the left-hand side, we know all the sizes beforehand. So we have the sizes for the femur and for the tibia, and one size polyethylene as a suggestion, but you have to get at least the other 3 or 4 sizes of poly just in case, because PSI is not really good in predicting the thickness of the polyethylene. This is something that you have to do inside the operating room because it all depends on your not only soft tissue release, but also on the dynamics of that knee, which does not show in a static CT scan. Occasionally, when I do bilateral knee replacement, when my assistant is closing the wound, by this time, the other knee, I already opened the knee, made the cuts with a PSI, and put the trial. I don't get this picture or I don't get this achievement in every bilateral knee replacement, but showing this means that I take about half an hour extra to the unilateral that I did, the first knee replacement that I did. It doesn't matter what is the speed of the surgeon. So if the speed of the surgeon, if he is even slow after finishing the first one or having the trial, I don't think he's going to spend more than half an hour just cementing and implanting. So there are so many benefits for the PSI, the ability to do difficult cases with the planning. It is better in bilateral knee, reduced operative time, less complications, especially fat embolus, less blood loss and transfusion. And this is already proven from the literature on robotics and navigation, which is the same principle here, because you're not going inside the medullary canal. Although robotics and navigation, they take longer time. This is a big disadvantage, because for bilateral, you want really to reduce time. And when you reduce time, you also reduce blood loss. Okay, so at the end, it's something preferred by not only surgeons, but also by anesthetist assistants, nurses, and managers. So my experience with bilateral simultaneous TKR is that when I work in the UK, US, and Canada, no experience whatsoever. I assisted in bilateral hip replacement when I was in Canada, but I never seen bilateral. Although it is done certain places, but for some reason I didn't have that experience. So when I came here and I told them about my earlier experience, and I was using conventional unilateral, and patient was not happy, and then I started doing the navigation. I did only one bilateral navigation, and I gave the person I know surgeons, like Arun Molaji in India, in Mumbai. He's great in doing navigation, and he told me about his experience in doing bilateral. But this is exceptional. Not every surgeon can do this. When you do thousands of cases of navigation, then you reach a stage where the navigation will take probably less time than conventional. So when I started PSI from 2009 until now, I'm sorry for this data, it is actually from last year data. Okay, so that's why it's written 2022. I had a steady increase in the PSI. So it started with probably less than 10% and then gradually increased. So nowadays, 95% of my cases are done with PSI. So why there is 5% not done with PSI? Because of other reasons. Either patient refusing, bilateral cannot afford, or there are some patients who wants, occasionally surgery very, very soon. And in this case, we do the PSI in about 2 days. But if it is less than that, we cannot do PSI. So one of the messages here is that PSI can loosen the criteria for bilateral simultaneous TKA. And this is an observation which is starting to become stronger and stronger, to the extent that we're going to present a paper with this title, with the PSI loosening the criteria. As you see the criteria on the left-hand side, and number 5 criteria is the deformity. So definitely with deformity, no problem with PSI. For other 4 criteria, we have many patients who are in the 80s who done bilateral simultaneous PSI, and results are really good. We don't have the problem with the age as such. The problem is how active they are, the patients, because occasionally you may find a patient who is in his 90s, but he really looks like 70s. Okay, so whenever we mention age, we mention activity, and it is the same here. So absence of cardiac diseases, as you can see, comorbidities here. If it is accepted by the anesthetist for a unilateral, they usually accept it for bilateral. So in this case, this criteria did not exist for our cases. The same for controlled diabetes. Once the patient is accepted for unilateral, the same for bilateral. With deformities, I will show you some data for a study showing a varus valgus inflection deformities, and we can see the results and comparison between them and others. Body mass index, we have many cases more than 130 kilogram who had bilateral, and we going into the statistics to see the difference. Definitely the outcome is not the same, but what you get in unilateral with the obesity is the same. So when I practice in UK, most of the hospitals, they don't operate on anyone who is more than 40 BMI. Okay, we have the experience of doing it more than 40 for the bilateral with good results. Let's see, this is a study which was done to compare between a bilateral simultaneous, and we're having 3 groups here. But all the 3 groups, they have deformities and comorbidities, okay? Comparison between bilateral PSI, unilateral PSI, and unilateral conventional techniques. This figure here, which is 764, is from last year. So now the figure is more than 900, approaching the 1,000 cases. And we decided not to submit the paper with this figure to come close to the 1,000. So right now we are working on the statistics. So these statistics you can see here, this is from early 2022, where we compared between these 3 groups. And the endpoint was the survival of the patients, including complication and survival of implants, and then also the function using a knee society score and range of motion. We have inclusion criteria. All of them, they had deformities, and all the records were recorded in the Egyptian Community Arthroplasty Register, which started in 2007. So with the inclusion criteria, as you can see here, consecutive cases, patient with deformities and with comorbidities, okay? So they must have a comorbidity, okay? Otherwise, we will not be able to present a paper on loosening the criteria. So with a but not every bilateral case that we did. I'm talking here about the study, okay? Not every bilateral case had the comorbidities. But when we talk about this study, and we found that about 60% of them, they had 3 of these comorbidities out of 5, which is the BMI, the diabetes, the cardiac disease, the obesity, the age, and the deformity, okay? So many of them, they had, as I mentioned, this criteria. With the exclusion, either uniCompartmental or revision. So here an example of inclusion criteria. Here a patient who with idiopathic juvenile arthropathy and having a bilateral hip replacement, which I did earlier before the knees. He was happy with that. I remember the anesthetist told me, if you can do 6 operations in this patient in one go, do them. I'm not going to anesthetize this patient again. And he had these 3 problems in hips, in knees, and also in the right ankle and subtalar joint. With severe valgus deformity, that I thought that this could compromise the outcome of hip and knee. So we did a bilateral simultaneous hips, and then we did a bilateral simultaneous knees, and then as you can see here, the arthrodesis for ankle and subtalar joint. But with exclusion criteria, patients usually who had either revision implant or bilateral stems, okay, as you can see here, for severe deformities like this, we tend to exclude them. Patients like this with severe deformities following chondroplasia, and as you can see here, although we do 95% of cases bilateral, but I cannot do a case like this bilateral. So he decided to do this as unilateral, one after another. When I did this case, as you can see here, the short tibia, which is impossible for any conventional technique to make a cut of the tibia, because as you can see on the left-hand side, the tibial jig, which is much higher than the level of the knee joint. So you cannot cut the tibia unless you cut it freehand or intramedullary, and you cannot go intramedullary because of the deformity. This is a patient with outcome, as you can see here. This is a video, but I think for the sake of time, I'm just going to skip this. It's just showing the range of motion. Also, this case is excluded, where you have a bilateral simultaneous TKR and unicompartmental using PSI in both of them. These are very few cases done this way, and these are excluded from the study. Also, what's excluded from a study when we do like a case with a revision, either with a hinged or a revision implant, and other case is a primary. Patients like this, the same also, when I have a case with a revision and a primary at the same time, these are excluded from the study. These are the results of the study. I'm coming close to the end. I'm really sorry being long. Here, this is the baseline characteristics. And as you can see from the statement at the lower end, that there is no significant difference in preoperative deformities or comorbidities in different groups. So they were more or less similar. And when we looked at deformities here, you can see 53%, they had 15 degrees of varus deformity, 4% had valgus. We don't have much rheumatoid here. That's why we don't have many valgus as varus, especially with bilateral. Most of the valgus are post-traumatic, which usually unilateral rather than bilateral valgus. 31 fixed flexion deformity, more than 20 degree. And this is significant data, that when you have 31% with a flexion deformity of more than 20. Severe deformities, as you can see here, more than 15 degrees. We had large number in the PSI group with a flexion deformity more than 20 degree. Again, large number with a PSI group. Hospital stay, nowadays, most of the patients are 2 days after bilateral with a PSI. We have very few patients who do the operation today and home next day morning. But these are few, but most of them, they just stay for 2 days. Significantly lower in both group of the PSI with regards to the hospital stay. Here, with regards to the long-term survival, there was no significant difference between these groups, but there was significantly improved score in the PSI group, where more than 60 in the bilateral PSI as compared to the conventional. I'm sorry, I can't see the title here for some reason. Anyhow, the complications here, as you can see listed on this, surprisingly, with regards to mortality, we had more cases in the bilateral. You may say that they had unilateral. We had more cases, in the unilateral group. You may say that these cases were not fit for bilateral, but in fact, some of them probably they had the knee on the other side. So this was not the reason, and this is a surprise to us. We don't know why. So basically, there are limitations for this study. It is a biased view of the developer of PSI. So we need a really multi-center trial. We need long-term results, and the technique that we're using, which I didn't have time to talk about, but it's called patient-specific templating as opposed to patient-specific instrument, or PSI, which is known worldwide by implant companies. We developed this technique and we use it in what we call hospital-based fashion. So this technology is based in the hospital, where we manufacture everything locally, and it is done locally at a low cost and in a very short time, up to 2 days. And also we do it for all implants and using a CT scan, and for very complex cases, as opposed to the PSI by implant companies, where they insist that you have to do it for straightforward cases. So in conclusion, bilateral simultaneous, it is safe with the PSI technology, even in severe deformities, complexity, and comorbidities. Mortality and morbidity and function were not higher in bilateral simultaneous TKR. However, the bilateral simultaneous is not standard until level 1 evidence trial is done. We know from Australian registry that bilateral simultaneous, which was done by computer-assisted technology with the robotics navigation, or PSI, definitely had less complications. And this is a very very strong paper I advise you to look at. Okay, but still we need further randomized trial to confirm our results. Thank you for listening, and I'll be happy to take questions.
Thank you so much, Professor Mahmoud, for this very interesting talk about this interesting topic. My first question for you, sir, what's the reflection of using PSI in total knee replacement on the soft tissue release?
As I mentioned in my comment, after the first talk by Prof. Murali is that the need for soft tissue release with computer-assisted surgery is really less. The cases where I do soft tissue release is patients with valgus or severe virus. But the virus that we get, which is 15, 20 degree or so, most of the time, if you do a perfect cut using computer-assisted technology, you remove osteophytes, then the need for soft tissue release is less and less.
I think, sir, the results of using the perfect results of using PSI is more or less dependent on good pre-operative planning. I'm right?
Yes. But the pre-operative planning with the software we have, which is a property of mine, it takes only 15 minutes for every knee. So if you're doing a bilateral, within half an hour, it is done. It can be done by an assistant surgeon. It can be done by any. It doesn't need an engineer. It's just done. You just follow the instructions on the software, saying, for example, where is epicondylar axis? Where is the level of the cut? Do you like posterior sloping? How many degrees? What is the thickness of your cut, or how much cut you want? And you can always make it default. So it can make like a default planning according to the criteria that I put, and then it becomes really short. And then if you're satisfied with the sizing, that's fine. If not, you can increase or decrease the size, and you can see immediately the effect of a changing sizing.
Why did you exclude revision cases, sir?
Revision, if you do bilateral revision, that's very, very risky, even if you're using PSI. So my advice, don't bilateral revision.
But for unilateral revision, you can do it.
Unilateral revision, I have many cases, and I actually have MSc thesis for one of our students who is looking at all bilateral cases where one side is done revision and the other side is primary, or the two sides are done using a tibial stem with a PSI. So because with this combination, the risk of, as I said, fat embolism is higher, okay, because you're going inside the medullary canal. So he's having this as a master's thesis.
Professor Murali, you have any questions, sir, or any comments?
I have a few questions. Sir, do you use a tourniquet for your surgeries?
I normally use a tourniquet, okay, but I know many of my colleagues don't use tourniquet. But when I use tourniquet here, my team well trained on the draping of this bilateral with a tourniquet, because we have the tourniquet with the two arms, right and left, okay. So we put the cuff, and we don't. I normally don't inflate unless the knife in my hand. I have this rule inside the operating room. I say, don't inflate unless I'm ready. I don't have to hold the knife in my hand, but to tell them when I'm really ready. So I just elevate the leg, and then for 3 minutes or so or more, and put the tourniquet up and start the surgery. And then I release the tourniquet after I put the polyethylene. So I always close after release of the tourniquet. I want to make sure that there's no bleeder that need to be controlled. And by this time, I start doing the other side and elevate the tourniquet. And the anesthetist is aware about the timing of that.
So what is your, what you're doing is actually sequential or simultaneous? Because there is a difference between the two.
Yeah, I know. I know the difference between simultaneous and sequential, but as you know, in orthopedics, there are so many terminology that are used not correctly, but it became the norm, you know? So what I'm doing is bilateral, sequential in the same setting, okay? But it used to be called simultaneous. I did few cases with two surgeons operating, like the one I showed with Zayoni. Okay, so actually my assistant was doing the knee. Who's a good assistant? I mean, he's a lecturer in orthopedics. He's good, experienced it. So he's doing the total, and I was doing the yoni as simultaneous.
Yeah, that's because the challenges between sequential and simultaneous are completely different. Do you reassess after the first knee what is the hemodynamic condition? Because when we used to do with my previous professor bilateral, I'm not much of a fan of bilateral, simultaneous or sequential myself. But what do you reassess after the first knee? What is the hemodynamic condition? Yes. What is the blood loss? And then you go for the second. And have you had occasion to abandon?
We have few cases where we had to postpone the second leg or knee. That's why I always tell the patient, please, which one you want to do first? Which one is worse? Okay, because this is the one which I'm going to start with a right or left. Okay,
yeah.
Just in case if I don't continue. Rare occasions actually where I did not continue, especially for medical reasons. Okay, because these patients are usually pre-assessed. We know everything goes well, because with pre-operative planning and a PSI, the surprises are very, very low. And unforeseen circumstances that normally happens are less. But we have occasionally, like for example, the other knee having the same size, and the company implant surprise us that they got like a one stock, although we tell them that we have two for some reasons. So it happened once that that don't. Okay, it's fine. So I'll just do one, and then we kept the patient, actually few patients, for 3 days, and the other one done after 3 days when the patient insists to have it on the same admission, and the anesthetist is happy with that. I mean, worldwide, it's accepted to do it after 2 weeks or 6 weeks or so. But I have few cases where it's done after 3 days, and it was okay.
But there's no problem on that.
Yes. I mean, if you do it bilateral in the same setting, then why you can do it after 3 days?
Exactly. I agree with you on that. And second thing is that you use your own software and your own planning and your own 3D printing, because otherwise the time delay in getting these PSIs is almost 3 weeks. Which is quite unacceptable to most patients.
Correct. And the problem is that the PSI did not have the good repetition on the literature, saying that, okay, PSI, what advantages of PSI? You're doing a CT scan, is a cost. You wait for about 4 or 6 weeks, and this is not convenient for many places, especially in private practice. And you have to stick to the same company, you have to do MRI, and MRI, there could be changes on the cartilage, because by the time I get the template, and maybe there is another delay for the surgery, or delay from the time of imaging till time of planning, whatever, all these can affect the accuracy of placement of the guide. So these are all the problems that happens with commercially available PSI from implant companies. That's why the PSI did not progress, because you may ask yourself the question, why robotics is now progressing even faster than PSI? Robotics is a $1 million device, okay, and a PSI is much cheaper. And the reason, what I just mentioned. So with our technology, all these problems are eliminated. We do it in 2 days. The cost is minimal, and we do CT scan, which is easy and affordable. CT scan here in Egypt, you can do it with like $30 or something like this. Okay, we do it for complex cases. We do it for any implant. You don't have to stick it to a certain company implant, and for all these reasons, it's much better. But because our literature is not known enough as compared to thousands of literature on commercially available PSI saying it is not really cost effective.
Well, that's fantastic, and thank you. I have no more questions, and congratulations. It was most informative listening and seeing your wonderful cases. Really, thank you very much.
Thank you so much.
Question, sir, please.
Thank you, Professor Hafez. That was an excellent presentation.
Yes, so
I just wanted to ask, did you say you get the templates, the jigs within 2 days after?
Yes.
Okay.
Yes. So it's actually, I didn't know if you know a bit of the history. I did a PhD on our MBD degree in Leeds Universities in 2001. Because I was working on robotics in 98 and then navigation in 2000. And then in 2001, I decided that robotics and navigation is not going to be the way forward. That's a decision was myself. I said, all right, we have to look for something really cost effective and simple. And that's why I did this on PSI. It just became gradually until idea became formulated and came as like this. And then I published in Clinical Orthopedics in 2006. And after that, from 2007 and 8, all implant companies in US started using the technology, and then it became everywhere. But I always made this comment that the way implant companies use PSI, they were defeating the objective. The main objective is to eliminate the conventional instruments. But when they use the PSI, they did not eliminate conventional instruments. They just made extra pieces to the conventional instrumentation system. So it became not cost effective. And
did you have to abandon the PSI jigs at any for any of the cases? And what was the reason you had to abandon?
Yeah, good question. For the femur, conversion rate is almost zero. And I say almost because I had only one case with an implant. I don't have to mention the name, but it is not popular. But this implant, the distal cut in the femur, has an inclination or sloping like the tibial slope, a huge inclination. Okay. And when I did the planning, we didn't take this into account. And this is the only time. And I don't consider this case as a conversion. It's just because it is a different implant, not familiar with. But after that, we use the jig for this implant, and we just changed the angle to make it fitting into this implant. So this is the only case in the femur. Okay. So apart from this case, it is zero. For tibia, yes, because the tibial jig, worldwide literature, it is not as accurate as the femoral jig. Okay, so in occasionally in cases of bilateral, I only use a femoral jig. I don't even use a tibial jig. I don't print it from the start. I do the planning and I make the sizing for tibia and everything, but I don't print the tibia because the tibia is already extramedullary. Okay, so it's not going to make difference with regards to the fat implants.
That's great. Regarding infection, say if you have infection in a bilateral case, if you have infection in one knee, what is the risk of having infection in the other knee also?
Yeah, good question, and I need to look at the literature because I remember asking one of my assistants to look at that because the picture I showed was a case of bilateral that came from outside Egypt. It was done in another country, and it was not done bilateral simultaneous. It was 6 months interval, but both of them got infected, and this is really rare. Okay, and I think after the webinar, I will send you that paper because I remember my assistant sent it to me. I didn't read it fully, but I will send it to you with all the figures on the incidence of having bilaterality or other joints, like having bilateral knee, bilateral hips, and then you get one joint infected. So what's the likelihood of getting infection on other joints, either knees or hips or shoulders? But it is rare unless the patient is immune compromised.
In your experience, did you find any such? You haven't found any such cases?
Did I find? Sorry, did I find what?
Infection in the second knee, getting after one knee getting infected.
No, I mean, in my case is not, but I'm looking at the literature or the case that came to us with a PSI bilateral. I will surprise you that the infection rate. I don't want to say it is less than the unilateral, but in comparison, as I showed in the figures, there was not much difference between the two. I remember having one case of bilateral, one unicompartmental, and one total, and one total got infected, and I found later on it was a TB.
Mm-hmm.
But the patient didn't give any history of TB from the start, and surprisingly, the other knee remained good after we treated. That was a revision.
So the other thing is, do you think it is a requirement for having a laminar flow theater to do bilateral knees? Because I think in the literature, at least for unilateral, there is a controversial stand on this. Some papers even giving higher rates of infection with laminar flow theater.
Okay. As you know, laminar flow is a trade name. Okay. So we should not use trade names. I mean, it doesn't matter what is the type of ventilation, as long as it is something accepted and it's something high quality. If you're having a HEPA filter, they are good. Okay. But if you don't have really a good ventilation system, then it is a problem for the unilateral and for bilateral. And I think this is a big challenge because we face the situation where many of the hospitals, they don't have really good ventilation system.
Thank you very much. That will be all from me.
Thank you.
Thank you so much, sir. Finally, I would like to thank Professor Murali Poduval, Professor Mahmoud Hafez, my dear friend, Dr. Srinivas, also OrthoTV for live streaming this event, and Eva Pharma Company for sponsoring this event. Thank you all. See you next Friday with another two eminent speakers from India and Egypt. See you next Friday at 8 p.m. Cairo local time. Thank you so much, and have
a nice evening, sir. Thank you very much for the invitation.
Thank you very much. Thanks a lot.
Thank you.
much and
Thank you. Have a nice evening, sir. Thank you very much for the invitation.